Hi, everyone. Welcome. I'm Christine Buckley, the host of the Brain Aneurysm Foundation's 1 in 50 podcast, here to raise awareness and provide education on a disease impacting at minimum 1 in 50 people. So thank you for joining us. All righty. Welcome, Dr. Khattar. I'm very excited to have you as a guest as the 1 in 50 podcast. How are you doing?
I'm doing great. Thank you so much for having me.
Yeah, and can you just tell me where you are? You are in Arkansas. What is your institution name and exactly where are you located?
I'm in Jonesboro, Arkansas. It's in Northeast Arkansas, and I'm at St. Bernard Healthcare. We're a regional center for the Northeast Arkansas, Southeast Missouri area, and we have a lot of folks down here that are in rural areas and a lot of farmland, and we take care of everybody that's in this area that comes down to the city, to the big city of Jonesboro.
I love it. Well, again, I'm fortunate that I've met you through the years through some of these national conferences. Dr. Khattar is also a recipient of a foundation research grant, and I know you're great with your patients and just really appreciate your time. So the main reason I want to chat with you, a lot was going on last week
Mhm.
about stress and brain aneurysms because of Kim Kardashian,
Absolutely.
and being the Brain Aneurysm Foundation, we've had a lot of people reaching out, not liking what they're hearing. How can you let this be said? So the way we look at it, brain aneurysms are getting some national attention, which is great, just on the awareness and education levels. But the thing is, as always, we want people to have the best and most accurate and correct information because we don't want panic or people thinking the wrong thing or trying to get treatment for the wrong thing. So I guess question number one, can stress actually cause an aneurysm to form?
I think that the biggest problem with the question is that we have to define what stress is. Stress is a very broad term that means different things for different people, and if you equate stress with elevated blood pressure, with taking up, habits or reverting to vices that kind of soothe the stress, like smoking, then absolutely, stress can cause brain aneurysms. But stress, just being anxious or being worked up about some specific event or feeling deep emotions about things may not necessarily cause aneurysms, or at least not as far as we know. I think that the most important thing to do, especially in this conversation, is to define the terms that we're using, because I think stress is very broad and means so many things for so many different people.
Yeah, absolutely. And I think that is probably the key to it. And I think it's, why you're having stress. And like you pinpointed, if it's blood pressure, you're smoking, those are the things that are then become the actual trigger. So can you tell us why an aneurysm forms? Do we know exactly why?
So, an aneurysm, by definition, is a weakening in a blood vessel wall in the brain. We don't really know why it forms, or at least the exact mechanism. We do know that it can be caused by specific stressors, such as elevated blood pressure, by smoking, that can cause weakening or further the weakening in the blood vessel wall and cause aneurysms to grow or to burst inside the brain, causing brain bleeds, called subarachnoid hemorrhage. Other causes of brain aneurysms are less known and less established. We have a lot of statistics, we have a lot of correlations, but such as drug use like cocaine can cause aneurysms, or amphetamines. There's some collagen vascular diseases that can cause brain aneurysms. But there's no direct established cause as to why a brain aneurysm forms that we know of, or at least nothing definitive.
Excellent. And so it's somewhat related, but different too. We have ruptured aneurysms. So I think it's also similar, right? Stress, like my having a busy morning and rushing in here isn't, if I had an aneurysm, that isn't going to be the cause of it rupturing. So what is it mechanically, or about blood pressure and say the aneurysmal wall? If someone has an aneurysm that's about to rupture, what are the real factors that could make that aneurysm rupture and weaken those vessel walls?
So So in general, a lot of the factors that cause the formation and growth of aneurysms can cause them to rupture as well. So sudden spikes in blood pressure, especially in folks that have chronically untreated blood pressure, chronically elevated blood pressure. For example, in that specific situation, a sudden event that can be equated to stress, such as, devastating news or a car accident or something that can spike their cortisol and their adrenaline very suddenly, especially in the setting of chronically untreated blood pressure, can spike the blood pressure so high that the weakening in the blood vessel wall and the weakening in that little pouch that is the aneurysm can just give out and burst and cause the subarachnoid hemorrhage to bleed in the brain.
Okay. And can you just say what are the risk factors and who's most at risk for having a brain aneurysm?
So most aneurysms usually we diagnose them and they occur in folks between the age of 30 and 60. Women, unfortunately, are at a higher risk of developing and growing and rupturing aneurysms, especially after the age of 55. African Americans and Hispanics also have a increased risk of developing aneurysms and of rupturing aneurysms. In general, we don't have a specific genetic cause for aneurysms, but we do notice that some aneurysms run in families, and especially if there are multiple first-degree relatives that have aneurysms, there's screening is definitely very important, as those can cluster in families. Most of the time, they're one-offs, and usually it's one member of the family that has an aneurysm for whatever reason. But sometimes, there might be underlying genetic factors that we don't know. And this is, the goal of all the research that we do with the support of the Brain Aneurysm Foundation, is in order to understand aneurysms a little bit better and try to figure out what are these underlying causes. But as far as we know, collagen vascular diseases are a big cause. If somebody has them, usually we screen for aneurysms, but in families can have them clustered together for sure.
Okay. Thank you. And what are the typical signs and symptoms of both ruptured and unruptured aneurysm? What would people be feeling? What would lead someone to believe they might have one?
For unruptured aneurysms, usually there are no signs unless an aneurysm grows specifically and compresses another structure in the brain. Sometimes it can compress, the third cranial nerve called the oculomotor nerve, and can cause a dilated pupil on one side. That some posterior communicating artery aneurysms can cause that, but beyond that, the great majority of aneurysms are asymptomatic. People just usually find them incidentally. Thankfully, brain imaging and vascular brain imaging has become very widespread, where people get them for a variety of reasons, whether they have migraines, whether they have headaches, whether they're looking for something else. And usually they find aneurysms, and then we see them in our offices. I think that the biggest thing about aneurysms is, understanding that having them isn't necessarily something that is incurable. This is something that we treat all the time, and then we treat very effectively. And the reason we are very aggressive with the treatment of aneurysms is because of how devastating a ruptured aneurysm can be. About 50% of folks with ruptured aneurysms usually end up dying, and about 2/3 of the survivors have permanent neurological deficits. So the statistics are pretty bleak in terms of rupture, and it's not because we haven't advanced the treatment of ruptured aneurysms. It's just because that the disease is pretty devastating to begin with. For ruptured aneurysms, the most important thing, usually if it's a very large rupture that involves a large amount of blood and is very aggressive, usually it's an immediate loss of consciousness is the biggest thing. But for folks who have ruptures that are smaller or at least a little bit more manageable, the most important thing that we hear is that this is the worst headache of their life, and it is A lot of folks come in and say exactly that in the emergency room. And, from my standpoint, somebody says, I have the worst headache of my life. They have a ruptured aneurysm until proven otherwise. And, I try to spread that message to my colleagues in the emergency department here at our hospital, as well as to all of our affiliate and partner emergency rooms or urgent cares that see folks in the community and in the greater, Northeast Arkansas area, so that we don't miss any ruptured aneurysms or misdiagnose them, because that's probably one of the bigger things.
Yeah.
Folks come in with a lot of headaches. If you ask somebody and you ask them, is this the worst headache of your life? If they say yes, then I think that it's very important to screen for aneurysms and make sure that they don't have a ruptured aneurysm, because a lot of times, especially in the first 24 hours, if a ruptured aneurysm can re-rupture, and usually the mortality rates are very, very high with a re-rupture. So catching those aneurysms very quickly and treating them, securing them, and ensuring that the patient is getting the appropriate care is very, very important.
Well, that was great. And I love that you are sharing with your colleagues, if someone does say that, to scan them, because something we are saying all the time to people, like you said, it's not the aneurysm that's terrible. It's the rupture of that aneurysm. And the treatments keep getting better and better and better, but we can't treat it if you don't know that you have it. So could you just say, what are the scans that would detect an aneurysm? What is it? An MRI, CTA, MRA, a combination? What's the best way to diagnose it?
Generally, for somebody that presents with with the worst headache, if they say that they have the worst headache of their life, the first scan that we do is a quick CT scan of the brain without contrast, without any dye. CAT scans are excellent at detecting blood, and we can tell very quickly if somebody has any bleeding in the brain within seconds of having done the scan. In order to screen for aneurysms, usually CT angiograms, which essentially is a CAT scan of the head and neck with dye that goes into the artery. So essentially, we give the dye and then we scan the patient early on as the dye goes through in order to see the big arteries in the head and neck. And that's how we can see aneurysms generally. With the computer reconstructions of 99% of CAT scanners these days, we can see very good images. An MRA is an alternative that has no radiation. An MRA, it's some quality of the MRA can differ, and CAT scans can be more reliably of good quality with the specific protocols in radiology. But a good quality MRA is just as good as a good quality CTA to diagnose an aneurysm. Obviously, the CAT scans and the MRI scans are non-invasive, and they are excellent screening tools. However, in order to characterize an aneurysm appropriately, the gold standard is a diagnostic cerebral angiogram. It's essentially the same as a heart cath, but for the brain, a brain cath, where it is a procedure where we go in through the wrist or through the groin and get a catheter all the way up to the arteries in the neck and inject some contrast dye into the artery of the brain, take specialized x-rays in order to see the blood vessels of the brain. The advantage to an angiogram is that the computer reconstruction of the angiogram takes away all of the different structures, such as the skull, the tissues, the water, the blood, everything else. And we are the only thing we see is essentially on a white background is the black shadow of all the blood vessels, and that we can look at them in great detail using those pictures. We also have the capability to do three-dimensional reconstructions where we inject some dye in the blood vessel, and then we get a specialized CAT scan that essentially creates a 3D model of the aneurysm in order for us to understand the anatomy, what is it neighboring, what is it adjacent to in terms of other blood vessels, and how we can best treat it with the tools that are at our disposal, these days.
Excellent. And because we are, advocating for patients to advocate for themselves, and this is why this information is important to really understand the signs and symptoms. So how important is it for a patient that might, hear this, and then maybe 6-9 months down the road, they find themselves with the worst headache of their life? How important is it for them to, wherever they may be presenting to suggest, I think I need a scan, or say, I think I have a brain aneurysm? Do you think it's important for the patient to take that extra step and just not say nothing?
I think it's super important, like a lot of, because sometimes just saying that will prompt the scan to be done in faster, and to prioritize the patient over other, less urgent folks that might be in the emergency department. And I think, that can definitely save a life, because if we can get to the patient and know that they have an aneurysm, and initiate the initial steps of the treatment, then we can potentially get them to the angiography suite and be able to secure the aneurysm, treat it, prevent the re-rupture, prevent the other complications that can happen, and then, potentially save their life.
Yeah. And this kind of goes into the next thing of misdiagnosis, which are things that we hear of sometime. And I also know in different parts of the country, not everyone has the same access to healthcare as others, and can be more rural, remote areas. And there's, medical professionals that aren't exposed to aneurysms as often as others. And that's part of what the foundation does, is educating primary care and first responder type people to the signs and symptoms, so they bring brain aneurysms into their differential diagnosis. So why do you think misdiagnoses happen? And, how can we maybe help try to reduce the level of misdiagnoses?
I think, sometimes there can be a tendency to minimize symptoms of headaches. Headache is such a broad umbrella term, and with no neurological symptoms, it can be difficult to ascertain whether a headache is serious or not serious. And I think it can be challenging for an emergency department physician, or somebody at an urgent care in a rural area especially, to like pursue every single headache with a full workup, because that can make things very difficult, because a lot of folks come into the emergency department with headaches. I think that the differential diagnosis and the big leap here is whenever patients come in with the worst headache of their life specifically, or a very severe headache. I think that's not scanning those folks is doing a disservice to the community, because while a lot of these scans might be negative, there's going to be one that isn't, and then that person
Right.
could die because they got sent home, and
Right.
then their aneurysm re-ruptured 6 hours later because they were doing whatever, and then they just died. So I think,
Yeah.
I think it's worth saving the life, especially, when we look at aneurysms that are at folks that come in with headaches that are severe. So I'm not saying everybody that comes in with a mild headache, oh, like my head hurts a little bit, but I'm okay.
Right.
That's not, those aren't the patients that we are screening for aneurysms. The patients we're screening for
Right.
aneurysms are patients that come in with severe headaches. And I think that's the key
Right.
point here.
Yeah, I agree with you, because that's certainly, we don't think anyone says they have a headache, they need to be scanned either. But through the
Right.
different people that we have met and that say we know have been sent away to either subsequently rupture or maybe get tested later, they kind of
Mhm.
knew there was something different with them.
Yeah.
So, it is definitely not your regular headache. And I think the other reason the education is important is because a lot of people who are able to walk into a doctor's office to verbalize like this awful headache, they oftentimes, they look like you or I, otherwise seemingly healthy. You're still standing and talking. So I think that makes it difficult too, right? When
I-
they really have to, I think, focus on that different worst headache of the life to help the practitioners, make that decision to get to the scan.
Absolutely. And, like
Um,
I said earlier, a lot of patients don't have any neurological symptoms other than headaches. And that's tough.
right.
That's a difficult
Yeah.
diagnosis times to make, especially because, as you said, they're walking in, they're talking, they're completely normal.
Right. But all right. So the next thing is, you mentioned before, incidental findings. So say like, and I know someone locally, was rear-ended, went to the doctors. He was actually an attorney for, people who do get in accidents and things, and he ended up thanking his patient, this woman, after the fact. And he said, I'm a
Yeah.
personal injury lawyer, but because of you, I went to the hospital, I got scanned, and I found out I have an aneurysm. He said, so thank you, because now I'm taking the steps to take care of that. But what generally happens if someone, has a report back like that? What is the decision to watch it, to treat it, how to treat it? What are the factors that get taken into consideration?
So in whenever a patient comes to see me, the way I think about it is that, we have to kind of classify the aneurysms into categories. And we have some studies that guide us based on population studies and prevalence of rupture. Obviously, these studies aren't perfect, don't include everybody, but I think they are a good starting point. And, some patients come in and, they found an incidental aneurysm. It's very, very small. It's 2 millimeters. It looks pretty round and smooth, doesn't have any irregular features on the CAT scan, on the CTA, and they have no risk factors. They don't smoke, they have no hypertension, they have no family history, they don't do any illicit drugs. Then I have more of a tendency to kind of watch it and see. I usually do short-term imaging on a first-time diagnosis, just to kind of see how the aneurysm is behaving. Does it look the same after 3 or 6 months, or is it something that is actively changing? If it's very, very small, like 1 to 2 millimeters, I usually just watch it over a short period of time, and then we can kind of go from there, and we can continue the screenings usually at increasing intervals if the aneurysm remains stable. If an aneurysm is a little bit bigger, I would probably try to characterize it up front with an angiogram, just to kind of know what we're looking at, and then also watch it serially, especially if it has no dangerous looking features in terms of the morphology. A lot of the things that we worry about are essentially irregular looking aneurysms. Aneurysms that look like perfect rounds are usually regular, and we don't worry about those as much necessarily. They can still rupture, they can still cause problems, but I would watch a regular looking small aneurysm with feeling more confident that it is less likely to rupture than an irregular looking aneurysm. I think if an aneurysm has multiple lobes, or it has small daughter sacs that just are very tiny areas where where the aneurysm itself develops a secondary, like microaneurysm essentially, and those are areas that would usually rupture more frequently in folks that come in with ruptured aneurysm. Other things that would relate to that is any other specific features. Is the aneurysm associated with other vascular lesions that would need to be treated as well? Some aneurysms are associated with arteriovenous malformations. It also depends on what the patient wants to do. How nervous are they about an aneurysm? If somebody has an aneurysm that is regular looking, and they get screened, we watched it, it looks stable, but it is completely stopping them from living their life because they feel like it's something in their brain that they would like treated. Is also, like, patient preference plays a big role in this, because you have to be able to live with the aneurysm, whether it is treated or not. So I think those are the things that play in initially in the initial phases of evaluating somebody with a new aneurysm diagnosis.
Excellent. That's great answer for that. And are there any, people ask us this a lot, any lifestyle changes or things that people can do or not do to help reduce the risk of potential formation or rupture of an aneurysm?
Absolutely. The risk factors that we know, the main risk factors that we know for development, growth, and rupture of aneurysms are modifiable factors. It's high blood pressure, hypertension, as well as smoking. So these are the two biggest risk factors, and they are both modifiable. And we folks can stop smoking and can get the control of their blood pressure so that it is no longer high. That can definitely help prevent an aneurysm from growing or from forming to begin with. Other factors usually are also, some of them are modifiable. Use of illicit drugs, cocaine, amphetamines, that can increase the blood pressure. They're all correlated to blood pressures a little bit in that specific regard. But if not doing illicit drugs that are amphetamines or cocaine is also something that can definitely be managed. Another thing that I think is important is if there's a family history, screening. Screening is super important, because knowing that somebody has an aneurysm and watching it and following it is a sure way of managing any potential impending ruptures. Because if an aneurysm is being followed and is being watched, and we get another scan and the aneurysm is bigger, or has some irregular features, then we would bring the patient in to do an angiogram and probably like proceed with treatment in the short term if we see that the aneurysm has dramatically changed. That would usually imply that the aneurysm is undergoing active changes and is essentially preparing to rupture.
Okay, that's great. And you mentioned screening for family members, which again, I think is super important. And I think, the foundation goes to Capitol Hill, advocating for more research funding. But another thing we've talked about when we are there and could become another initiative is that currently, the rule of thumb seems to be you need 2 or more people in the family to have had the aneurysm for then the scan to be paid for. And,
Correct.
even the folks on the Hill always say to us, why would you wait for that second incidence? So do you think we can ever get to that point if there is one family member, again, because being a national organization, hearing stories from all over, it's oftentimes one person has it. They do a little research, found out that's what took their grandmother or this other aunt, and nobody really knew or talked about it. And so I think it is, I'm hoping that we get to the point that if there's, a family member that does have it, that that insurances, like you had said before, you might scan 50 people, 49 could be negative, but if you save that one, it's really important. So how do you feel about screening family members if there's just one so far that's known?
I mean, I get frustrated too with this rule where you need 2 family members, because I think sometimes, a lot of folks just don't know. A lot of folks like died suddenly or when they were younger or a long time ago, when the screening tools were not really readily available or accessible for a lot of folks. So I think that's definitely frustrating, and I think we can get there. I think as we learn more about aneurysms and through the research work supported by the Brain Aneurysm Foundation and by other national organizations and the federal government, we learn more about aneurysms and we learn more about the devastating sequelae of aneurysm ruptures. We talk about the 50% mortality rate, 66% permanent disability rate of the survivors. But like even the folks that don't have any permanent disability have, their lives are very different. They are, even though they might be able to work, they are more irritable. They have more cognitive problems. They have more mood problems. They have a much greater difficulty, um, living in society normally than we realize. And that's kind of the silent struggle, because they look fine but they have a lot of difficulties. So I think that
Absolutely.
the consequences of an aneurysm rupture are tremendous, and they don't end when the patient survives and they walk back to the office a year later and they're like, oh, I'm doing fine. Fine is not necessarily like amazing. I'm not back to normal. I'm not back to my normal self. I survived this whole ordeal, and now I have to deal with all these consequences. I may not be able to go back to my job if it required a lot of like a high executive function, meaning like lots of processing, lots of decision making, lots of rapid sequence thoughts. I may not be able to tolerate the things I used to tolerate before. If the job is very stressful due to not only cognitive issues but also mood issues, where they're unable to tolerate stress, they get angry, they get depressed, they get anxious. There's a slew of issues that happen after aneurysm ruptures that are secondary consequences that we don't even think about. So I think the burden of aneurysm ruptures is so large, and I think it's larger than we realize. And maybe we realize it. I think as the professionals in the field that take care of aneurysm patients, and I know you realize it as the Aneurysm Foundation. But I think the general public doesn't realize that even though mom survived her ruptured aneurysm, it got treated, she doesn't have an aneurysm anymore, we're screening all the time, she feels better, she's walking around, she went back to doing to working or to doing whatever it is that she wants to do. She is struggling every day, and that is not insignificant. So I think as we learn more and as we increase awareness as to the burden of aneurysm ruptures, I think that we will get to a point where screening for aneurysms with one family member will become way worth it when it comes to these secondary
Right.
downstream problems that can occur, that can, not only that will automatically increase the cost of healthcare as we go, because a lot of those patients will need care of some sort. It may not be,
Right.
like inpatient like physical therapy care or specialized long-term acute care, but it's care nonetheless that the insurance will have to cover. So I think screening and preventing
Absolutely.
happening will prevent those downstream effects from ever occurring. And I think that's way
Yeah.
better.
Yeah, no, absolutely. You just kind of surmised that oh so well. And that's, I mean, could actually be a whole nother podcast because it is awful. It's something, we struggle with, and why the support groups are so important because, again, after people are treated, they can have, say, a 10, 15-minute conversation. If you just meet them, you wouldn't physically know that they had this. And you hear they had a brain aneurysm, and it almost does a disservice because someone doesn't know what it is. Like, well, it can't be that bad because I see
Yep.
you walking and talking and look fine, but it's all those invisible deficits that people don't see that they have inside. And, that is, I mean, you just kind of summed that up really well. So I appreciate you understanding that because we do hear from patients, all the time. And that's why, again, the support groups are so important, which is why we're going to get one going down in Arkansas soon. But
Absolutely.
that's another conversation too.
Yeah. We're
But,
very excited.
before we go, I do want to ask you, like, what do you think is the biggest myth or misunderstanding about brain aneurysms? And like, what is the one takeaway you really want people to have after they hear this?
I think, I think the stress causes aneurysm line. I think that line of thinking it increases awareness about brain aneurysms, and I think that's good. But I think it can cause undue panic, where who isn't
Right.
stressed today? Everybody has some stress in their life. Stress is kind of how humans have survived over thousands of years,
Right.
in order to conquer the mammoths first and conquer fire, and now to get to work and deal with everyday life. um, I don't
Right.
think all stress is bad. I think defining stress is going to be the biggest thing. And I think if I could say anything to patients is like, yeah, your high blood pressure, your diabetes, your other secondary risk factors that are contributing to the persistent elevated blood pressure, to the smoking, to any illicit drugs, all of those risk factors are way worse than any stress you have from a job, or from like a minor car accident or something
Right.
something little. An aneurysm isn't going to form from that, but I think years of hypertension, of high blood pressure, are much more likely to form an aneurysm than bad news, or feeling stressed out, or being in
Right.
difficult situations, even for a prolonged period of time. I think if those situations
Yeah.
come with the physiological effects of elevated blood pressure and other soothing habits, or soothing habits as they are perceived, like smoking, that definitely can cause an
Right.
aneurysm. But I think that the biggest thing is that
Right.
not every stress causes an aneurysm. And the
Great.
there's no need to panic. And if you think you have an aneurysm, get checked out. That it get
Right.
screened. Coming to the doctor's office and saying, I've had headaches, if you've had headaches or something like that, can definitely trigger a screening test, especially if those headaches are persistent. um, and then we'll know. Knowing, I
Excellent. I
think, is
really
all
appreciate.
knowing. So
Yeah, no, I appreciate you addressing the stress issue specifically based on the last week. We don't really know the full story there. We never know anyone's, actual case unless you're the doctor and you're seeing the scan. But in any event, the awareness of brain aneurysms, came to light, which is certainly helpful. Educating people is always great. And from
mhm.
my perspective, it's getting ahead of the rupture, right? We want to save lives. We want to keep families and communities together. And we can only do that if both the patients and the physicians are aware, know the signs and symptoms, and communicate, and patients advocate for themselves, or sometimes they might need the family to do that, but they can't do it without information like this. So Dr. Khattar, I want to thank you so much for taking your time out of your busy day to share this information with us. And, hopefully we'll chat soon.